of a psychological trip down pain, so pain management, like what people deal with when they're talking about pain. So if you are in sensation and perception, it is going to be a little less biological. I just went through the slides are there, slightly different from sensation and perception. I posted them as they exist fully on Brightspace, but I don't think we're going to be able to get everything. It's like 38 slides in 50 minutes. Not something that I can do without like breezing through them all. So to get us started,
my plan was to keep me up all night. I didn't know what to do. I finally told my doctor what was going on, and I'm glad I did. I found out there was a lot I could do to manage my pain. I'm taking yoga now and walking every day. I've even signed up for a water aerobics class.
Hell yeah.
I'm taking care of myself. And you know what? It's working for me.
Great.
To manage your pain, visit the Michigan Department of Licensing and Regulatory Affairs Pain Management website at michigan.gov/PM.
That's a good PSA, and I forgot that I had it set to just play when I went to the screen. So, Michigan, they were really great in the 90s telling people how to manage their pains. Alright, so before we jump into pain management, a couple of definitions I think is useful. So, acute pain. Okay, this is acute pain. Aw, it's cute. This is pain that comes from tissue damage. Okay, so broken limb, laceration, that sort of thing. Acute, generally by the nature of the time, when we compare it to the other kind, which is chronic, right, is less than 6 months. So most acute pain, when you're talking about it in a pain management setting, you are essentially talking about the moment of injury. Okay, so I have acute bronchitis or something like that, right? So the bronchitis is going to come and it's going to go. That's the nature of the acuteness of it, okay? And I was talking earlier in the week about seeking treatment and identifying symptoms, interpreting symptoms, and pain being a great motivator. Acute pain, and depending on its severity, is an extremely big motivator, and relief from that takes a significant amount of priority, right? So you're gonna go to the doctor, right? On the other hand, we have chronic pain. Okay, so this is the other side of the coin. This is after 6 months. So chronic pain lasts a long time, and lots of people with chronic pain deal with that pain for their lifetimes. Okay, so even if a single injury caused or a single malformation or growth, a tumor or something like that, even if that resulted in acute pain to start, once you hit that 6 month mark, it's now chronic pain. You're now dealing with chronic pain, and chronic pain is a psychological task unto itself, okay? Because that pain might last a lifetime, okay? There are 3 kinds of chronic pain. Chronic benign pain, which is unresponsive to treatment. So if you have chronic pain, so pain lasting more than 6 months, that does not respond to any sort of treatment, then it's chronic benign pain. And so an example for you is that, and many of you have probably have some form of chronic pain. If you don't, and I am envious. So I had a congenital defect in my ankle that required surgery when I was about 11, 12. So I had that, I had the surgery, but my ankle's not ever the same. Wasn't ever the same, and it will never be the same. I will likely use a cane when I am older, because it's just deteriorating. You may have caught me walking on campus with a limp here and there. So it would be classified. So the pain that I feel from it would be classified as chronic benign pain because it doesn't respond to NSAIDs or any kind of pain over-the-counter pain relief. It doesn't respond to any sort of steroid treatment. So it's a bit of a bummer because I need my feet to walk on. Recurrent acute pain. So this is pain that comes and goes, but over the course of 6 months or longer, okay? So you have acute pain, but then you can have recurrent acute pain, so it maybe it lasts for 2 weeks and then it goes away. But and then it's like gone for a month and then it comes back for 2 weeks and then it's gone for a month. And so once you're past that 6-month mark for this, it's now a recurrent acute pain. It's still chronic, even though it sucks. So the best example of this one is for those of you who have migraines. Okay. Even normal run-of-the-mill tension headaches technically fall under this, but because they fall under more of a common ailment than anything. I mean, a tension headache is pain, but responds to treatment and goes away. It's generally speaking, they don't have the same cause. Migraines, however, seemingly are a specific form of headache that affects the person's other senses, and it's sort of debilitating on its own. So for those of you who do suffer from migraines, they are a special kind of headache pain. Okay. And so that would be considered recurrent acute because they suck when you have them. And then there's chronic progressive pain, which is often referred to as hyperalgesia. And so hyper means more, a lot, right? Above, exaggerated. And algesia is Latin for pain. Okay? So hyperalgesia, there we go, is pain that lasts more than 6 months and gets worse over time. Okay? So cancer would be considered chronic progressive. Rheumatoid arthritis would be considered chronic progressive. So those are the 3 kinds of progressive pain. Okay? Now my question to you all is, who experiences chronic pain in class? I'm an A, I'm an S, I'm a yes. What about you all? I'm interested to see the breakdown here of chronic pain. I like this music too. Pumping. Alright. So we got... What do we got here? More or less yes. More or less yes. Oh my goodness. That is a lot. Y'all are 20. Why? Stop it with the pain. Y'all are 20. Shouldn't be happening. Anybody want to share what their chronic pain is? Only share what you want to share to the group. You can drop it in chat. Joint pain, okay. Lupus, yep, that's gonna do it. That is gonna do it. Lower back pain, that's a bummer. That's like one of the worst bits of pain to have is in the lumbar region. When we got a new bed, oh my god, that sucked, because it takes your body about a month to readjust to a new bed, especially if your bed before that was shite. And so we got a new purple mattress, and it's wonderful, I love it, but it took me about 30 days to get rid of my lumbar pain. So Knees, headaches, 110%. Lower back for Emily as well. Horrible knee injury in high school. A few years of physical therapy still bothers the crap out of me. Yeah, knees are a pain in the ass. A chronic pain in the ass. Get it? That's my crusty laugh. Oh. No, there's my other crusty laugh. Migraines, plantar fasciitis, knee pain. Oof, y'all. ACL surgery. Well, if that lasts more than 6 months, then it is chronic. But right now, that's technically acute. Headaches. Whoop. All right, moving on. Thanks everyone for sharing. So, because we're talking about this in a health psych class, we got to talk about clinical pain. So, clinical pain can exist in, I think I did put three on there, maybe 2 on there. Ow. Talking about pain, my neck hurts. All right, so it's just the 2, right? It's just acute versus chronic. That's right. Pain sucks, as we have already discussed. Maladaptive coping, and I think the one thing that we can talk about, even though I have like catastrophizing and wishful thinking up there, maladaptive coping on this one I think is perfect, since we didn't get time to talk about it on its own day like I had originally planned. Opioids. Okay? That's maladaptive coping, because chronic pain is insufferable, and it sucks, and opioids are insidious, but also immediately helpful. But in the long run, they're not helpful at all, because you gain a tolerance, and then you need more and more and more, and then people overdose, and then people end up dying, right? And so we have this now secondary health challenge, right? It's an ongoing health challenge, but right now it's obviously secondary, right? The pain control techniques that we are going to talk about toward the end of class today, useful for acute pain, but not really useful for chronic pain, unfortunately. Chronic pain, and specifically chronic pain management, is the biopsychosocial model in detail, right? So whatever clinical pain you feel right now, whether it's acute or chronic, they have different ideas surrounding them. There's different ways to deal with them, and there's different psychologies around them, okay? How you think about it. So, obviously pain hurts, okay? We have it because it's adaptive, it's critical for our survival, and we get feedback from our bodily systems, especially those that we have no conscious control over, right? Keep us alive, right? Feeling pain when we, hurt our skin is important, because if we hurt our skin, then we don't want to bleed out, and we don't want to let microbes in. So there's a lot of important reasons for pain. It lets us know how to stay alive, right? In concert with our discussion at the end of Wednesday's Wednesday's stream, where we were talking about patient-provider miscommunication, well, here's an additional one. Here's an additional layer with pain. So, from the patient's perspective, the pain is the problem. The pain is the problem. And sometimes this is the case. Sometimes this is literally the case. But unfortunately for the patient, the provider's miscommunication comes in because pain might not necessarily be the problem. It might be the byproduct of the actual problem. But patients are so focused on the pain that they just want the pain to go away, that treatment may get lost by the wayside, right? And we also talked about, when seeking treatment, that pain can also be psychological. Somaticizers, social pain, cultural pain, okay? Other psychiatric illnesses can increase or decrease the pain felt by somebody, right? And so, just as a small tangent, you can experience social pain. So we talked a little bit about this on Wednesday, I believe, and then if you're in sensation and perception, this will be a bit of a review. So social pain can be in the form of grief over death, right? That's painful. And so here is Chuck from Castaway, okay? And he lost Wilson. And he was grieving for Wilson. Wilson! On the open seas. You never do hear from Wilson again. He's probably floating around the Pacific Ocean now. But of course, the boat found Chuck. Okay. Another kind of social pain that you can feel is social rejection. Okay. Being rejected. This is also referred to as ostracism. These friggin' kids right here are being real mean to this girl. Okay. We'll all take a second and tell them that they need to stop. Or they will be hated people. When they are older, we'll hate them all. We will not be tolerant of their intolerance. Astrid's like, what are you talking about?
Like, what Mean Girls? Like, actual Mean Girls? Wow.
Well, no, it's two dudes apparently, and one girl that are laughing at this other girl who feels sad. Who's being, she's got some emo going. She's got some real good emo energy on this wall. On this wall that's very graffitied, you know. Lots of graffiti. So yeah. Now there was one study that I wanted to share with you all that explored the social pain of ostracism. And the findings are pretty cool, pretty incredible when you think about it. So, being ostracized threatens our deep need to belong, right? We need to belong. We need to affiliate with people. No man is an island, as the saying goes, right? And if you ask people who are feeling isolated right now, real pain is experienced. It sucks. Increased activity in the anterior cingulate cortex, which fires when we are under significant amounts of pain, mostly acute, but, you know, if you've got if you've got recurrent acute pain, then that also fires there. And so, if you have somebody take acetaminophen, Tylenol, it will, people report feeling less pain, right? Obviously, it works on your inflammation response, so you'll feel less physical pain, but people report that they feel less social pain, right? So, it's really crazy. It's wild. It's wild. It's wild. That social pain does this to us. And then the other thing that I wanted to share is that there is a racial empathy gap. This is from an old article from Slate, I think from 2012, I think is what it is. No, 2013. I don't feel your pain. And so this was an article in Slate about a recent publication back in 2012, 2013, where researchers found that white participants assumed black participants and black people in general felt less pain in sort of a pain viewing paradigm. Okay. Obviously not. Okay. 18. They asked people about 18 common scenarios. Okay. The interesting of the, I mean, that findings doesn't seem surprising, right? But here's the other thing. Black participants also said that black people felt less pain in these scenarios. Like stubbing a toe, getting shampoo in your eyes. So, black participants also felt that about black people in these scenarios. And then, and this is not great, nurses also thought that black people felt less pain overall, as well as nursing students. Okay. So there's definitely a racial empathy gap. Okay. Everybody feels pain, and you feel it the same. Same as in quotation marks. Because it's a mystery. Magic. There's not a lot that we know about it. There's the physiological experience, but beyond that, there's really no psychological underpinnings. Yeah, I showed that people use the same pain words, culture to culture to culture, which is, important. Lots of exclamations, like ow, ah, ugh, ah, ugh. Yeah, so lots of onomatopoeias, okay? Pain has incredible amounts of interpretation. So not all pain is equal to everybody, right? Not all of the same pain is equal to everybody. And the description of pain between people interpersonally is going to be affected by how mysterious it is. And pain is always construed in context. It is always going to be impacted by the situation, okay, that you find yourself in. Okay? So, ask those ultimate fighters, those MMA fighters, when they're in the octagon, how they feel when they get when they get a huge gash from an elbow right across their face, and they're like, I didn't get a gash. I don't know if you've ever gotten blood in your eyes, but blood in your eyes is very painful. And many of them get blood in their eyes, and they just keep fighting. They're just like, So pain is construed in a context, right? But imagine you running up to somebody and it's like punching them in the face. They'll probably be like, oh, why did you punch me in the face? I'm gonna have a huge gash. Why did you punch me in the face? 'Cause I felt like it. And then you run away. It's gonna be you're gonna feel it much worse if you were the one. And then pain is cultural. There are lots of ideas about pain from culture to culture to culture. Who should feel the pain? What pain should be felt? Should it be shared with others if you are feeling pain? So on and so forth, right? I'm gonna throw these up here. So most of the time, pain is measured in one of two ways. The first way is very diffuse. It doesn't really actually tell you anything about pain, except the body's response to the pain. So that's what an autonomic arousal, so heart rate, blood pressure, galvanic skin response, etc., and then electromyography, so EMG, is going to tell you. It's just the body's response to the pain, as opposed to measuring the physiological nature of the pain itself. So keep that in mind. Keep that in mind. The other way that pain is measured, and this is the main way that pain is measured, both in the medical profession as well as in psychological studies, is through verbal report, okay, or self-report questionnaires. So two of the more, that's missing a closed parenthesis. Oops. Two of the more common ones are FACES and the VAS. It's the Wong-Baker FACES. That's what this is up here. And it was, so that came out in 2001. Oh, this is the revision of the Wong-Baker. Hicks was the one who revised it. And so if you are dealing with a nonverbal kid, that you can just have them point to this one, right? So it's a scale from 0 to 10, and most of these scales are from 0 to 10. But if, again, another verbal one is the visual analog scale, which is like, place your finger somewhere on here. It's also a 0 to 10. When you're verbal and everyone else around you is verbal, the nurse or the doctor will be like, whoa, what pain are you experiencing now? 0 being no pain, 10 being the worst pain you've ever felt. And so then you respond with a number. But these two are useful for nonverbal situations. And then you can even go further by asking the McGill Pain Questionnaire. Melzack is the guy who created the gate theory of pain with Wall. So this was created up at McGill University, MPQ. So this is a little bit more involved than just a single number. And then you can also measure pain behavior. This is quite a bit more involved. It's observational. It takes more planning. Okay, but we all have behaviors associated with feeling pain. Like I mentioned, limping. I also mentioned ow and other onomatopoeia verbalizations. There's also avoidance behavior. Okay, so these are all ways that you can observe somebody experiencing pain without directly asking them, "Hey, are you in pain right now?" Okay. Genes are important. I'm going to skip this one. We're going to skip the physiological stuff about pain. I will settle on this one, though, because I do want to describe the difference between the two fibers that go in your spinal cord and let your brain know that you are feeling pain. There are two kinds of fibers. A delta fibers and C fibers. They could also be referred to as fast fibers and slow fibers. Okay, and the reason one's fast and one's slow is because of myelination. Fast is myelinated, slow is unmyelinated. So A delta fibers, their job is to send sharp pain up to the brain. Okay, past the go signal. Pass the go signal and tell your somatosensory cortex, yo, that hurt. Okay. C fibers, on the other hand, are slow. They transmit dull pain. Okay. Dull pain that may or may not pass the gate. Okay. In the spinal cord. It may or may not pass the gate. You can see that dull pain doesn't actually go up to the cortex. See, the A delta fibers go up to the cortex. The dull pain doesn't. Okay, dull pain doesn't, which means that you can habituate to the dull pain much quicker. Still there though, still there, and it's not nice. It's unpleasant. It's just a constant feeling of unpleasantness that you can't get rid of. Okay. It's a dull pain that's kind of just subliminal for you to recognize. Okay. One other thing that I wanted to mention about the physiology of pain, before we talk about the factors that influence pain and the experience of pain and pain management, are these three molecules. Substance P is secreted by those A, delta, and C fibers in your spinal cord that send signals back and forth, generally speaking, upward. And it works with glutamate, which is a neurotransmitter. Okay. Enkephalins are endogenous opioids. So these are opioids that we make. Okay. they bind to opioid receptors on our neurons, and they regulate how substance P is produced. So, therefore, how much pain is going up to the brain. Okay, so those are enkephalins. And then we have endogenous opiate peptides, which are protein molecules that are, again, made by our body. They're opioids, or opiates, okay? And the most famous one that you're probably aware of are endorphins. That's an endogenous opiate peptide, okay? And it essentially acts as a redirector of information, okay? It reduces the pain signals across your body. So that's why when you hear about runner's high, that's generally speaking endorphins that are redirecting information from your legs, your knees, your feet, that just suffered large amounts of trauma from striking a hard ground, right? Our knees, generally speaking, aren't built for running on hard surfaces, okay? And that's pretty much what most people run on. And so runner's high comes from the fact that endorphins are like, whoa, let's turn that down. All of it way down. Okay? And then so it feels good. It feels good. You're like, yeah, I want to do that again. It's sort of an interesting feedback loop. Okay? So those are the three messages that chemical messengers that I wanted to chat about before we switch into more psychological gears here. And so, before I forget, one of the last things we are going to talk about is the Stevens et al. Paper, which is swearing and pain. Definitely read that for the final quiz if you haven't read it yet. It's available on Brightspace. Stevens et al. 2009. Oh, it's 11 years old now. Wow. Okay. So, factors that change the way experiences or pain is felt. I don't know what I'm saying. Chronic pain begins to creep into our lives as we get older. Okay. And there are a lot of folks who would argue that it is essentially a normal consequence of aging, right? Our bodies do deteriorate. They do. It's a fact of life. They deteriorate, and it's just going to happen. And when tissue starts deteriorating, well, you're going to start feeling some pain, right? Gender, there are gender differences in the experience of pain. Women are more likely to report symptoms overall, just like I mentioned earlier this week. Experience more frequent episodes of pain. Okay, I mean, we can talk about one that happens to women, girls and women between, puberty and menopause, which is menstrual pain. Right, that happens every cycle, generally speaking. So, yeah, more frequent episodes of pain. Males do not have that, right? They don't have something cyclical like that, a cyclical biological process like that. And so, of course, there's less reporting of pain. Okay. Overall, this is overall, women do report lower pain thresholds and less tolerance to painful stimuli than men. But I have my doubts on this one. It really depends on who you're asking. Because there have been several non-scientific things where you give men muscle stimulators and you put them on their groin, and this mimics labor pain. It's not obviously labor pain because it can't be, but it mimics labor pain. And men of in their 20s and their 30s get this attached to them, and they can't do it. They can't do it at all. They're like, ah! It hurts. Take it off. And so you're like, can they? Are they better at being more tolerant of pain? I don't think so. I think it depends on who you ask. Ask any guy who has been hit in the testicles how much pain tolerance that they can take. Am I right, men? Am I right or am I right? I mean, at least that's from my perspective. Okay. So yeah. And this interesting finding about lesbian and bisexual women, lower pain intensity than straight women. I think this was a cold pressor task. This Vigil et al. Study, cold pressor task. So that's cool. Anyways, gender differences, they're a thing. Whether or not they're in the way that statistics report, I have my doubts. We'll see. I'm a bit skeptical about it. Okay. SES and stress modulate the way that we feel pain. So if we're under more stress, we feel more pain. Lower SES folks tend to suffer more chronic issues, which are resultant from other things that we've talked about in class, like cardiovascular disease, cancer, respiratory diseases, just by the nature of growing up more impoverished and with less access to healthcare, that sort of thing. So lower socioeconomic status tends to compound these other features of a person's health and well-being, which then leads to the experience of more pain, right? And here is where pain is the byproduct of these underlying features and underlying issues, right? Culture and ethnicity, again, pain tolerance versus pain threshold is an interesting cross-cultural thing to study, right? So an example here would be tattooing, right? Tattooing. It's something that's considered mostly cross-cultural, but there are cultures who do tattooing way more than other cultures. And so you can then ask these cultures what their tolerance of pain is versus the threshold of their pain. Murphy just came down here and then went behind the green screen, and I have no idea where he went. Murphy, what are you doing? Just being weird. Your mood and your personality can affect how you feel pain. So the MMPI, this is technically the MMPI-2, Minnesota Multiphasic Personality Inventory. Hysteria and hypochondriasis are two subscale scores that if you score high on, can indicate that you probably have lower pain tolerance and an increased pain intensity than people who score lower on these things, right? So, and then we can throw in mood here. People who are anxious, worried, fearful, depressed, and negative explanatory styles report more pain. Okay. And you can actually subtype these individuals. I don't really like typology when it comes to personality, as many of you know. But clinically speaking, these are clinical subtypes of pain patients. So dysfunctional pain patients tend to report high levels of pain, feel that they have little control over their lives, an external locus of control, and are extremely inactive, right? So this is you can see why this is dysfunctional. Interpersonally distressed patients, little social support, and feel other people in their lives do not take their pain seriously. Whether or not these two things are true is another question, okay? An empirical question, obviously, but these people have the perception that they don't, right? So they are interpersonally distressed. And then we have adaptive copers, okay? Adaptive copers, generally speaking, report lower levels of pain and distress and continue to function at a high level, okay? So those are the three. And I'm going to move on from social learning. You can skip that one. Let's end these next 9 minutes of class here talking about treatment, broadly speaking. So we can end with the Stevens stop. So there are 4 major sort of kinds of treatment for chronic pain. And if you don't know anything about CBT, guided imagery, then that's, take a wild stab at it. Take a wild stab. Take a walk on the wild side. Caffeine addiction. All right. Be careful, those of you who are selecting opioids. Be careful. All right. Most would choose exercise. Okay. There's still some movement going on. Great. So we're not going to talk about all of these. And what's included in exercise right here. Oh, I can just reach out and touch it. There it is. Yeah, touchy. What is included in exercise would be something like physical therapy. Okay. CBT is more of a reforming thoughts and behaviors to reduce pain. Opioids, obviously, are drugs to reduce pain, bind to pain receptors and tell that information to go to hell, that pain information to go to hell. And then guided imagery would be closer to CBT as far as it being psychotherapy, but using imagery to reduce pain. It's more of a distraction, more of a distractory thing. All right. So, pain management, treatment of pain. Who gets chronic pain? Everybody. I mean, come on now. Genetic predispositions, degenerative illnesses, old folks. Everybody. Everybody gets chronic pain sometime in their life. Okay? Now, if you're lucky to not have chronic pain until you are elderly, then kudos to you all who have those, right? One thing to, if you have chronic pain earlier in your life, one thing to make very clear is that it does take a negative toll on relationships, because pain is a motivator. Pain is a consumer. It's an all-consuming kind of thing, which can have a negative toll on your relationships. So just nurture those relationships as much as you're trying to nurture your pain relief. This is what I would say. Obviously, we have pharmacological treatments to treat pain. Okay. Opioid analgesics. Okay. They, like this morphine up at the top here. Morphine. Okay. So they're still referred to as narcotics. Most narcotics are Schedule 1 classified, which means that there is no medical benefits to them whatsoever. I say most narcotics. There are some that are used, obviously, medicinally, like morphine. Okay, but heroin is a Schedule 1 because there is no medical benefit from heroin. Okay. Opioids are agonists, and so they mimic your endogenous opioids and attach to those pain receptors and change the way that pain is felt, essentially reducing it. Then we have OTCs, that over-the-counter medications that are peripherally activating. So these are things like NSAIDs, non-steroidal anti-inflammatory drug. That's what NSAID stands for. Okay, non-steroidal, so they're not steroids, anti-inflammatory drugs. And I have acetaminophen because that's one of the most common NSAIDs out there. But then you have ibuprofen, you have naproxen sodium, which is like Elusive, okay, and then a few others out there, right? So these are an anti-inflammatory drug. Not to be confused with aspirin, which is a blood thinner, okay? Aspirin is formed from the bark of a tree that I cannot remember, and it was the main pain reducer until NSAIDs were discovered and invented. So you can also take something like prostaglandin, which is an injection for localized pain and inflammation reduction. Okay, but if you take too much prostaglandin too often, then it actually will sensitize nerves, which means that you'll feel pain more intensely as you. So prostaglandin should be used sparingly, as far as I'm aware. Surgery to remove the thing that's painful. So obviously this has been used the most frequently in the course of history. Oh, your leg's hurting? Let's just cut it off. It's fine. Your arm is hurting? All right, it's gone. Your head is hurting? Well, I could kill you. One of the things that psychosurgery used to be was like destroying thalamic cells, lesioning thalamic cells where the pain is being felt. You have to use so much care in this one because you could destroy like other connections. But people who suffer from deep burning pain, that's just constant trigger of those C fibers. As I showed you, they go up into the thalamus. You just singe those and hey, boom, done. Deep burning pain's gone. The difficult thing with deep burning pain is that finding a source is going to be incredibly difficult. So surgery in this way can at least bring relief to the person, okay? However, because pain is such a mystery, that psychosurgery should really not be attempted unless it's the only other option, right? Some personal pain control techniques that you can use just on your own is a thing like counter irritation. Okay, so it's analgesic in the sense that the initial pain is counteracted by a other demanding stimulus. So how many of you get bug bites and scratch around the bug bite? Because the bug bite's itchy, right? And so you want to scratch around it, and that brings some momentary relief. I do that. So that's a form of counter irritation. The other thing is if you get some form of bite or something like that, you can slap it, and it's not as bad as scratching it, getting like, you know, germs and stuff up inside the bug bite. You can like slap it. That's also counter irritation, right? For those of you with lower back pain or back pain, you can use transcutaneous electrical nerve stimulation, or TENS. So this is counter-irritation in the form of stimulating the spinal nerves that are near the pain, which is why it helps on back so much, because they're right next to the spinal cord, of course. Right? So here's an old multi-patch one, and then Icy Hot has developed their single pad one. Shaq will tell you all about it if you go look at Icy Hot commercials, because Shaq is Shaquille O'Neal is the spokesperson for Icy Hot. Dull the pain away. You know what I'm saying? Goes on cool, comes down hot. I don't know. That's Icy Hot. I don't know. Whatever. Distraction is another way to manage pain, right? So being focused elsewhere, might reduce pain. Like, hey, look at me, ha ha ha, I'm dancing around as you get a shot. Whoa, you got a shot, cool. See, well done, little child. So that's how we've handled kids getting shots. We've tried to distract them, with like videos or other things, sucking on sugary drops, right? You can focus on something else or reinterpret that pain experience. And then the other one, which is my personal favorite, is swearing. Okay, so Stevens et al. Had people do a cold presser, and then they had one group do, and they also they studied men and women, and so they separated gender effects out, and it was within subjects. So the person either, and this was counterbalanced, so they either did swearing first or control first. And so they got to choose what swear word they wanted, but then they just had to keep repeating it while their hand was submerged. So they could use shit, they could use fuck, they could use, most people chose those. And then during the control condition, they said something benign like table, and they just repeated table. So they were like, hand in the cold pressure, shit, 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 and then they did it again after a period of waiting. They did it again to return to baseline. They did it again. They're like table, 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 right? And here are the findings, right? Swearing increased the amount of time people had their hands in the cold presser. They perceived the icy pain less, and their heart rate increased during swearing. So, their conclusion was swearing produces a hypoalgesic effect under certain conditions because it induces a fight or flight response. So next time you're in pain, go for it. Just swear all over the place. Just scream it at the top of your lungs. Stub that toe. F! Alrighty. Be sure to read that. It's an easy read. And it's also real good. So Stevens et al. 2009. And if you have any questions, let me know. I know we went really fast through this, and my apologies in that case, but I wanted to make sure that we were finished with this so we could talk about CAM and only CAM next week. So yeah, have a really good weekend, everyone.